Welcome. Today we're diving into a critical but often overlooked aspect of activity intolerance, the role of skeletal muscle. For decades, the three-gear model has been used to explain how our bodies produce work, highlighting the heart, lungs, and muscles as key components. While heart and lung assessments are routine, the muscle component is frequently ignored, leaving a gap in our understanding of why some people struggle with activity. Let's explore why skeletal muscle is the missing gear and how it impacts our ability to stay active. Physicians have a variety of tools to assess the heart and lungs, such as lung function tests, chest CT scans, EKGs, and echocardiography. These tests are well established and supported by dedicated medical specialties, making it easier to pinpoint issues in these organs. However, when it comes to activity intolerance, focusing solely on the heart and lungs leaves out a crucial part of the equation. Without considering skeletal muscle, we may miss the real reason behind a patient's limitation. Skeletal muscle is more than just tissue, it's a dynamic organ essential for movement and activity. When we're out of shape or medically deconditioned, it's often our muscles that are holding us back. Yet muscle function is rarely assessed in clinical practice. This oversight means that many cases of activity intolerance remain unexplained, simply because we haven't looked at the whole picture. Do you know that about one-third of activity intolerance evaluations end without a clear diagnosis? Even with advanced tests like non-invasive cardiopulmonary exercise testing, the cause often remains a mystery. If skeletal muscle isn't considered, we might never identify the true source of a patient's limitations. This highlights the need to broaden our approach and include muscle assessment in our evaluation. Peripheral dyspnea refers to activity limitation caused by the aerobic capacity of skeletal muscles. Surprisingly, this concept isn't emphasized in most pulmonary training programs, despite its prevalence. Many clinicians, even those deeply involved in pulmonary medicine, may overlook this common contributor to activity intolerance. Recognizing peripheral dyspnea is key to understanding why some patients struggle with physical activity. Research has shown that inactivity can dramatically reduce aerobic capacity. In fact, peak oxygen uptake can drop by as much as 30% with inactivity, accompanied by changes in muscle capillarization and mitochondrial density. On the flip side, increased activity can boost VO2 max by a similar amount. The difference in fitness between someone who exercises less than an hour a week and someone who exercises over 6 hours is equivalent to a 35-year age gap. In the medical world, preserving lung function and improving walking distance can be incredibly expensive, sometimes costing up to $100,000 a year. Yet the benefits of regular exercise on skeletal muscle are profound and cost nothing. This should inspire us to pay more attention to muscle health, especially when simple interventions can yield such dramatic improvements. It doesn't take long to lose fitness. Even short periods of bed rest, such as during a hospital stay, can lead to significant muscle loss. This rapid deconditioning is well documented after events like COPD exacerbations or ICU stays, and it can be worsened by medications or underlying diseases. Even healthy adults aren't immune, just a few days of inactivity can set back months of progress. Estimating how common peripheral dyspnea is can be tricky. Among patients with unexplained activity intolerance or dyspnea, up to 12.5% have problems with peripheral oxygen extraction, and 8.5% may have some form of myopathy. These rates are even higher in people with conditions like COPD or heart failure. Peripheral dyspnea is also a key feature in post-COVID syndrome and in those returning from military deployment. Certain groups are especially prone to peripheral dyspnea. Patients with chronic illnesses, such as COPD or heart failure with preserved ejection fraction, often experience muscle-related activity limitations. Similarly, those recovering from COVID-19 or military deployment may find that muscle dysfunction is a major barrier to regaining their previous activity levels. Recognizing these patterns helps tailor interventions for those who need them most. Why do we so often miss the muscle component? First, there's no widely accepted non-invasive method for diagnosing muscle-related activity intolerance. Second, unlike the heart and lungs, skeletal muscle doesn't have its own medical specialty. Third, muscle dysfunction overlaps with many other conditions, making it harder to pinpoint. Finally, even in advanced training programs, there's little emphasis on prescribing exercise as a treatment. One of the most remarkable features of skeletal muscle is its plasticity, its ability to adapt and change in response to activity or inactivity. Unlike the heart or lungs, muscle can improve dramatically with the right exercise program. This means that even patients with significant limitations can often make meaningful gains simply by moving more. Exercise isn't just for athletes, it's a powerful prescription for anyone struggling with activity intolerance. Unlike medications or expensive treatments, exercise directly targets the root cause in many cases, deconditioned muscle. By making exercise a routine part of care, we can help patients regain function, improve quality of life, and even reduce healthcare costs. Despite its importance, assessing skeletal muscle remains challenging. There's no single test or specialist responsible for muscle health, and muscle dysfunction often overlaps with other medical issues. This complexity means that muscle-related activity intolerance is frequently missed or misattributed to other causes. Raising awareness among clinicians is a crucial first step. In summary, skeletal muscle is the missing gear in our understanding of activity intolerance. By recognizing its role and making exercise a routine part of care, we can address a major source of unexplained limitations. The next time you encounter a patient with activity intolerance, remember, sometimes the best prescription is simply to get moving.